Let me first start with what is the Digital Health Seminar. Well, yeah, we probably already know what the Digital Health Seminar Series is an event that we organize in order to disseminate research applied into healthcare. And it is a team at the moment of 5-6 people at the moment. And it's basically about this, developing international interdisciplinary connections between academics, healthcare professionals, industry. Online, we have other members of industry also attending as part of LEAP, which is a digital health hub in the southwest of England and Wales. And we organize this event every 2 weeks. The location usually changes, but it's around the Clifton campus. And in person, we can only have people from the University of Bristol in order to access to the facilities, but online can join anyone. Then before we start, if we are in person, we will pass you a tablet to register your name. We just want to keep track of how many people attend in person. This session will be recorded and made available online. If anyone has any concerns, just let us know. For the online attendees, please stay muted. In principle, you should already be muted. And then the presentation will be 40 minutes, and then 10 minutes at the end, 15 minutes to ask any questions. If you are online, use the question and answer option, or just write your question in the chat. Maybe you want to make the question yourself, just let us know. We can see if we can arrange that. And then today we have Jingjing Liu from University of Bristol. She will be talking about human behavior modeling in naturalistic environments for healthcare. She is a research associate in the School of Computer Science at the University of Bristol. She is working in the EPSRC-funded project Taurus, and her research interests are in computer vision systems to assist in healthcare. She is currently working for Parkinson's disease and have worked in the past with children with autism. And she works on methods or vision methods to estimate human pulse and action. Then, yeah, without further ado, let's welcome. Maybe I need to share this other one. This one. No, it's not this one. This one. There's this. Okay. And yeah, thanks for coming.
Okay, yeah. Thanks for the introduction, and good afternoon, everyone. I'm very delighted to have the opportunity to give the talk today.
My backpack, sorry.
Okay. Yeah. So my name is Jingjing Liu. Currently, I'm a research associate working in the School of Computer Science at the University of Bristol. My research topic today is about human behavioral modeling in naturalistic environments for healthcare, with a particular focus on real-world, robust, and clinically interpretable human behavioral modeling. So firstly, I'll give an illustration of the research background. So I think the human behavior, it covers a variety of items, including the hand gestures, actions, attention, emotion, languages, and so on. So the estimated and predicted human behavior can be applied to different applications, such as surveillance, healthcare, human-machine interaction, and therefore it has been the research hotspot in recent years. And my primary interest is about healthcare. Then I want to give our view of the recent progress of AI methods for human behavioral modeling. So in the early start days, the input comes mostly from the RGB images and videos, and we use the CNNs as the backbones to deal with this data. And then the RGBD cameras becoming popular and less costly. So it introduces additional depth information, but the background is still relying on the CNNs. And on this basis, human skeleton has been extracted and or estimated. So compared with the RGB and RGBD modality, it is much more compact and still meaningful and information has rich information to represent human motion. And then graph convolutional networks were developed to deal with the skeleton since it's quite a topological structure. And then with advanced of AI methods, the transformers has arisen as a much more stronger backbone within the better capacity. And then when it comes to more recently, the multimodal fusion has become the trend. For example, RGB video, depth video, human pose, even with IMU and audio. All these different sources of data can provide complementary information, and the stronger models also arise. For example, the diffusion model as the representative of the generative modeling. And I think the future trend is that we build upon this multimodal fusions and we want to generate some real world impact. So this page is about the core scientific problem. Despite of the significant progress of these AI methods, when it comes to applying in the real world, there are still several challenges. And here I summarize them into three aspects. So the first one is closed world environments. While most existing methods, they were trained and inferenced on the laboratory settings, but in homes and clinics, such real-world environments, they are often dynamic and heterogeneous. And the second challenge is stationary behavioral distributions. As we know that the behavior they varies across individuals, across contexts, and even over time. And the third one is snapshot-based diagnosis. While currently the clinical practice are often episodic assessment, but in reality, we know many neurological conditions, they will evolve over time. So that requires much more than snapshot-based diagnosis. And all of this leads to the key question here. How can we reliably measure and model naturalistic human behavior to develop clinically deployable system to support assessment, diagnosis, and intervention? And then I'm going to introduce my past and my current research experience. And this can be broadly categorized into two parts. One major part is about the algorithm development for human behavioral modeling. And the other part is about how do I develop systems for the clinical applications. So I will begin with the first part. And it progressively incorporates three parts. So in my very, very early study, I did some works about the 3D skeleton-based human action recognition. I were using the controlled lab data, like the common publicly benchmark data sets. Then I shifted my focus towards the data collected in the wild. It means data collected in real-world environments, and then I explored the multi-view, multi-modal fusion settings for tasks like action detection and emotion recognition. And recently, I did some work about unsupervised cross-domain 3D human pose estimation. And also recently, I turned my focus to the real-world deployment, which suggests the resources is usually limited. So I explored the knowledge distillation to make sure it's resource aware and efficient. So it aims to generate a smaller model, but keeping the performance or even improve the performance. Now I'm going to introduce one of my work in detail. It's about unsupervised cross-domain 3D human pose estimation. So firstly, I want to make clear what is 3D human pose estimation. So the definition is given an image or video. The goal is to predict the 3D locations of human body joints in space As we can see, this is the common pipeline in this area. So given a 2D image, the first step is to derive the 2D poses, which means the 2D joint coordinates on the image plane. And then the next step is to lift the 2D poses into 3D poses, while the 3D poses are the 3D joint coordinates in the camera's coordinate system. Since this step, the 2D pose estimation, it has been a quite mature area, while the existing methods are quite robust. So mostly when we refer to 3D pose estimation, we mean the next step, like how do we lift from 2D to 3D? And that's also the focus of this study. Well, the 3D poses, it can provide the depth and spatial information. So that is crucial for downstream tasks. For example, we can use that to analyze human motion and also be used for the rehabilitation assessment or something. And the next question is, why is cross-domain 3D pose estimation challenging? Well, models trained in one domain, they often perform poorly in another domain due to the domain shift. For example, if a model is trained on human 3.6M, this is a large-scale human pose data sets collected in the laboratory. The pre-trained model influenced on the outdoor data sets such as 3D HB or 3D PW, the performance will have a large drop. So according to previous works and our summary, here are three key factors contributing to the domain gap. The domain gap means the difference between different domains or different data sets. So the first key factor is the camera viewpoint and the position. So different viewing angles and camera locations lead to significant positional changes in 3D space. So the data, they have different distributions. And the second factor is about human motion or posture, that different actions and postures increase distribution diversity. For example, maybe in this laboratory collected data set, most actions are more stationary, like people work slowly or people sit, people stand, but in the outdoor could be some more obvious actions like people jogging or running. And the third factor is about body size. Different body proportions affected bone length and scales. And among these key factors, we observe that camera viewpoint and the position is the most significant factor contributing to the domain shift. And based on this observation, here inspires our key idea. So before we go to the idea, first I want to explain a bit how does the existing methods work for this issue. So as the title here, ICU provides the cross-domain. So the input for this problem is to incorporate two parts. One part is from the source data set, one part is from the target data set. And here 2D poses are input data and 3D poses are labeled. Since it's the IC provides the setting, so for the target data set, we don't have the 3D poses as the label. So this is taken as the input. And the common pipeline is we augment the poses from the inputs. And this augmented poses is also called the synthesized data. So it has more diversity. They were used to train the pose estimator. So in this way, the augmented data can help generate a better pose estimator, a more robust pose estimator. So we hope this pose estimator can have better performance on this target data set. And also we use the discriminator. So we train the whole framework in an adversarial learning scheme work. And when we talk about the pose augmenter, like how do we do the pose augmentation? There are mainly three types of augmentation. So the first one is we modify the bone angles that corresponds to the human action and the posture changes. The key factor affecting the domain shape I mentioned just now. And for the second one is we modify the bone length that corresponds to the human body size factor. And the third one is we do rigid transformation for the whole 3D pose, and that corresponds to the camera viewpoint and location factor. And so for this, okay. And this is the existing framework, and we want to tackle the factor of the camera viewpoint and locations. And the way here is to do rigid transformation. But when it comes to review the previous methods, like the common way to do is to do a randomly initialized rotation and transformation. So if we see here, the blue skeleton is the source 3D pose. Like we apply rotation and translation, so it augments some data, but the synthesized data here, it doesn't definitely match with the target data set here. So our idea is like this. We want to explicitly compute of the rotation and translation matrix. So we generate some synthesized data which can match well with the target 3D pose. And given this idea, we developed the method here. So firstly, because we want to match with the target data set, the target 3D pose, but to be honest, we don't have the labels here. So firstly, we need to generate some pseudo labels for it. Yeah. And so the first step is we do the pseudo label generation. I'll give some details here. Like here, we use some constraints like the boneless consistency, reprojection constraints, and finally we have the pseudo labels. It gives a rough estimation of the target 3D poses. Then we want to see how do we actually compute the rotation and the translation to make the synthesized data matches with the target domain. So here we design a human-centric coordinate system in advance. So this coordinate system is building considering the topology structure of human skeleton. So we set the origin as the hip joint of the human skeleton. And also we define the X, Y, Z axis. And given this coordinate system, we call it H. It can be used as a bridge. So we have the source 3D pose. It's under the source camera's coordinate system, CS. And then we can calculate the rotation and translation from CS to H. And similarly, we have the pseudo target camera coordinates data, and we can calculate the rotation and the translation matrix from H to CS. And finally, we can calculate the rotation and translation from the source camera's coordinate system to the target coordinate system. And in this way, we can achieve the idea we proposed just now. And we evaluated the proposed method on several publicly benchmark data sets. And we can see the proposed method, it surpasses the previous SOTA methods with quite a big margin. And it even surpasses the fully supervised method on some setting. So here is the summary of this work. So all of this starts from the observation that camera viewpoint and camera position are major sources and domain shapes. Then, inspired by this, we have the idea that we want to generate the explicit rotation and translation. And then we proposed the method of pseudo-label guided global transformation. And the result revealed the method achieved the SOTA performance. And in the future, I want to turn my focus on domain adaptation for population with disorders, for example, the Parkinson's disease. Sorry. Yeah.
When you generate synthetic data,
yeah,
do you generate synthetic skeletons, or do you also generate the synthetic 2D images?
So I just sincerate the poses. As I just said, this study focuses on lifting 2D poses to 3D poses. Yeah, so the input is only 2D poses. Yes,
The input is 2D poses, and then
yes.
you generate synthetic different positions.
I generate 2D, 3D pose pairs. Yeah. Because 2D is the input data, 3D is the labels.
Yeah.
Yes,
But if you change the subject in any way, you also generate the corresponding 2D image of that change.
Yeah. Okay. Like I use the camera intrinsic parameters to reproject, so I have the 2D poses. Yeah. So except for this purely algorithms, so another major part of my research is about developing systems for the real-world healthcare applications. And here I want to introduce my current work. Is about Parkinson's monitoring, and this is also my role as a research associate for the Taurus project. So I want to give an overview of the whole project first. So the project's goal is to enable continuous, objective, and unobstructed monitoring of Parkinson's symptoms in daily life. So firstly, we start from the clinical need. Like the Parkinson's symptoms fluctuate over time. Like it may changes even over one day, like before or after the medication, their symptoms will change. But the clinic visits are sparse and subjective. So it is obvious that objective measurements at home are needed. And our vision is to move the assessment from the clinics to home so that can enable long-term and continuous monitoring. So we want to achieve home monitoring by enabling multimodal sensing. So in this way, we can achieve the quantification of behavior to support better care and also drug evaluation. So in one sentence, Taurus project is an interdisciplinary research project aiming to build a real-world deployable sensing system for Parkinson's monitoring in daily life. And it mainly incorporates two parts. One part is a wearable part, one part is a camera part. And right above it here is for the camera part. So here is the overall system architecture for the vision-based sensing system for this project. So firstly, after we evaluated the metrological performance and the camera's performance on downstream vision tasks, we selected the Intel RealSense D456 as the input. It's a very nice RGBD cameras. So given the collected RGBD data, they were processed on an edge device that is NVIDIA Jetson Orin Nano. We selected this device as the edge computing device because of its high performance, low power, and the real-time processing capacity. And then the processing pipeline covers like these several modules. I'll give it a detailed explanation in the next page. Now, like we can have the quantified behavior, and its outcomes can cover some metrics, for example, some mobility, gait, turning, sit-to-stand action patterns. And in the future, it will be used to support clinical monitoring that will aim to attract the symptoms over time in daily life at home. And even in the longer future, it will be used to support drug evaluation, since we can quantify the changes before and after treatments. So here comes to the core computer vision pipeline here. So gives the input from the RGBD camera. The first step is we estimate the 2D human poses. And then combined with the depth information from the camera, 3D human poses can also be obtained. And the next step is for identity, the person. So this part, it comprises 3 modules here. Like firstly, we can do the face recognition. Like we can tell from the person's face area, so we can know who is who, because in most times of the home settings, there is not only the patient, maybe the family members, visitors will also appear. So we need to make sure which person is the participant, and we only measure that person's behavior. So here's identity is a very crucial function to be enabled. But as we know, the face recognition works well when people's faces are visible, but if they turn back or their faces are occluded by something, then the face recognition may fail. So we also combined with the tracking module and building upon the recognition, face recognition, tracking, and pose estimation. We enabled the person re-identification, which can tells like this person who is the participant across the time. And building on the recognized person, and here we measure their skeleton. So our aim is to quantify and analyze their behaviors. And here lists some possible outputs. I think they are in the future, but should be our goal. For example, we need to tell the gait speed, count their steps, and for example, their turning durations and so on. And here is the example of our current deployment. We have already deployed this system in a British style house. And now this system supports 3 scenarios. The first scenario is we collect and record raw RGBD videos. This is mainly for our early stages, like we want to give scripted instructions to the participants. So we record data, annotate data, use this data to train the models. And scenario 2 and 3 is more for the free living scenario. It's more designed for the for the real patient's home deployment. Like we need to consider their privacy protection. So here, one of the functions is we can achieve the gray level and the blurred RGBs on clips recording. As we can see, this person, his facial area is blurred and the background is blurred. RGB colors are removed, only gray levels are kept. So we want to protect their privacy, but we also want to get some data. So it's like a balance between them. And also, I think so this way, we try to keep their privacy to the maximum degree. Just here, we only record their skeleton, like their raw RGBD videos are processed in real time. So we only keep their ID and their skeleton. They can be used later for quantify their behavioral features. Well, this is the project is still ongoing. So here I summarized the previous challenges, current challenges, and also the future directions. So I think the challenges come from mainly 2 sides. One part is about the technical challenges, one part is about the clinical side. So for the technical part, I think the most important thing is the efficiency and real-time deployment. As I just said, we want to protect the patient's privacy. So we better deal with the data, the raw data in real time, and only keep those features like for later analysis. So the efficiency is quite important. And the second one is the domain shift, because our aim is to apply these systems into different households. And for different homes, there must be some different, we want to keep the settings same, but there must be some differences, like the lighting or camera location could be slightly different. And we also need to make sure it's used for long term. So maybe even weeks or months. So could be sensor failures or some consistency. That's all need to be considered about. And for the clinical challenges, I think the first one is about clinical validation. So behavioral metrics clinically meaningful. So for this challenge, I think currently we have solved it to some degree by collaborating with the clinicians. Like we collaborate with interactions, combining their professional evidence. For example, after talking with the clinician team members, like they said, the turning duration, the sit to stand duration is a very important indicator for the symptoms of Parkinson. So we treat that as one metric we need to measure. And I think the second important part is about patient acceptance. It's mostly about privacy, trust, usability. So to solve this, we spent quite a few time to engage with the patient council, like we regularly have meetings to discuss and talk their concern, and we also want to show them our progress. And also, I think this is more for the longer future, is about the clinical trial integration. So how can the behavioral measures support treatment evaluation? And I'm afraid this is quite far in the future, so leave it for the future. And according to my understanding of my role in this project, I think for the future, the directions could be these 3 points. So firstly, I think the project is quite creative in terms of long-term data collection, because currently most studies, they collect the data for maybe a few minutes or a few hours, but for this project, it supports maybe weeks or even monthly collected data, so we can do some longitudinally symptom modeling. And the second one is to tailor the models adapted to different individuals. That is also personalized monitoring. And the third one, I think is very clinically meaningful. It's about the treatment response assessment, but this has to be achieved after we collect some, more the clinical data. So I think that's the previous part about the current project I'm working on. And next, I want to introduce another application, which was my study during my PhD period. So it's about the autism early screening. And similarly, first I want to give an explanation of the disease. So autism spectrum disorder, namely ASD, is a common neurodevelopmental disorder affecting social interaction, communicating, and behavior. So according to the WHO, the global prevalence is about 1 in 100 children worldwide. And why is the early screening important? Because the studies and surveys reveal that earlier detection of ASD can support earlier intervention, and earlier intervention can generate better developmental outcomes. So we turn back to see early screening is very important. And currently, the clinical practice follows this way to do the assessment and the diagnosis of this condition. Like the clinician, they follow the professional schedules, and then they interact with the child. During the interaction, the clinician observes the performance of the child, and then, according to the observation, they scores for different modules of these schedules. Well, for this common diagnosis process, it has some challenges. Firstly, it's time-consuming because there are multiple sessions in that schedules, and in fact, there are several schedules to be completed before a very formal and actual diagnosis. And the second is this process, it requires trained specialists, but there is a very limited number of experts, and therefore it's high workload. And because the whole process is dependent on the clinical observation, so the process is subjective and variable. And here gives the overview of the system we developed to assist in the early screening of autism. As we can see in the left picture here, so this is the hardware setting. We have multiple cameras. One is the Azure Kinect, is one RGBD camera, and we also use two Logitech RGB camera positioned at different angles. And during this process, we also collect the audio data. And here shows the, I think it's like the software architecture. Like we get the input data from different sensors, and then we enable different modules, like the face recognition, pose animation, object detection. And on this basis, we can estimate people's gaze, recognize their emotion, movement, hand gesture, and so on. So since we can collect several different items of people's features, now I want to explain how do we achieve the early screening. As I just said, the diagnosis process is the clinician follows schedules to interact with the children. So firstly, we collaborate with the clinicians, and based on their professional experience, we proposed a series of screening protocols. These protocols are simplified than the diagnosis schedule. For example, there are response to instruction protocols, joint attention protocols. So for each protocol, the clinician follows the protocol to interact with the child. And during this process, our system collects their data, generates the features, and given the multimodal features, we used a tensor fusion method to fuse them. It's basically calculating the outer product of the features from different modalities. And then the fused feature is taken as a joint behavioral representation, taken as an input into the machine learning model, and the output is the score of this protocol. So the score is firstly annotated by the clinician, and in this way, we train the machine learning models. And for each protocol, it gets a score, and we sum up all the score. If the score is higher than threshold, then we consider the child is an autism level. So for another side, I want to talk about, we also did something to enhance the model's interpretability. So here we use the shape value. Here are some equations. I'll skip this because it's used to measure the contribution of different features for how do they contribute to the decision making of those machine learning models. And here I give an example. Like here I visualized their mean shape value into the decisions making, and we can see the first feature contributes most to the model output magnitude, and that corresponds to the yield angle of the children's head pose. So in this way, the shape-based interpretation enables clinicians to understand the model's decisions and increase trust in the system. And here shows the software of the system. This is an interactive page for the clinician to operate. Like they follow this tool, they start collecting data. After finishing the interaction process, they can click these buttons and it start analyzing and output a report finally. And here shows the visualization demo. This one, the children's hand key points and their pointing directions. And this one is about the head pose animation to show their attention. And this is more about the object detection. Yeah. So here is the summary of this project. Firstly, regarding the screening results, we have 4 protocols in total, and we did the studies of regarding 57 participants, and for each participant, the data lasts about 15 minutes. And as I just said, if the summing up score is higher than threshold, we take it as autism, or else we take it as typically developed, that is normal children, and the accuracy is about 82%. And on the other hand, since we can quantify the children's behavior, we can support to do some clinical related analysis. It's about the statistical analysis. So we can do some variability analysis, for example, can review the group difference between different behavioral measures, such as their gaze patterns, response latency, and can also try to explore with the correlation analysis, the correlations between different behavioral indicators. And to talk about the impact of the system, it has been launched in several hospitals across China. When I did this study, we collected 57 children's data. Now it has collected more than 200 children's data. And the mechanism for this system is working like this. So we launched this system into the hospitals. We don't need the specialist of autism diagnosis. We just require a normal clinician. So this clinician, he or she follows this tool and interacts with the child, and the system outputs a report. If it says the child has a high risk for the autism, so the child and his parents can go to the hospital to have a standardized diagnosis. So this can help a lot for the early screening and also help for the timely intervention and also to get better developmental outcomes. And here is my future plan. So in the future, I will still focus about advancing behavioral modeling in naturalistic environments for healthcare. So here I list the 3 directions. The first one is I will still focus on developing robust behavioral modeling systems and also considering the edge intelligence. And the second one is I want to model the evolution of clinically meaningful symptom trajectories. And since the LLM has been very popular recently, I want to leverage it to expand the clinical concepts into structured behavioral level semantics. So thereby we can enhance the model's clinical interpretability. Yeah. I think that's all. Thanks for your listening and questions are welcomed.
The questions in the room. You can also check online if people has any questions. But yeah, meanwhile, I think I noted some questions. Yeah, for example, you showed some of the scores that clinician provided for the autism.
Oh.
And I think I saw different types of tests, probably. No, before you showed different tests. Here, yeah, protocol scores.
Yeah.
And there are different protocols, no?
Yeah, yeah.
I just wonder which one did you use? Do they usually agree, or which score did you try to use as a target, or an average, or?
I think, yeah, well, for different protocols, it has its own score, and I sum up, add them together as the overall score. If the overall score is higher than threshold, then it's treated like this is an autism level.
Then you aggregated multiple scores.
Yes.
And you use that as a target during the training. During the training, how?
That's a bit different. Like we train the machine learning model for different protocols. Oh, I see. For this protocol, we train. Oh, okay. Yeah, it's score prediction. Yeah, yeah. That's it. Yeah, yeah. Mm.
Does the screening tool perform particularly differently amongst different levels of autism because it's such a heterogeneous?
Yeah. To be honest, the autism is like a spectrum disorder, and could be the serious degrees. But to be honest, it could only tell two kind of classification whether you have or not. I think if we want to generate different levels of prediction, it requires more delicate design. Yeah. Yeah, that's all. Yeah, but that's a good direction. Yeah.
On the 3D pose estimations that you were showing, as a first step, you had 2D. 2D estimation, and then later you added the 3D component. Here, yeah.
Here?
Yeah, as a first step.
Okay.
No.
Is this one or previous one?
Oh no, yeah. The second point, you estimate using 2D human key points, and then in the third step, you add the depth. Is this actually the order? Or is it you are showing this as an example? Meaning that is it good enough usually the 2D alone to estimate the poses? The first step, or?
I think 2D poses represent the human motion to some degrees, but as you know, like the 2D information doesn't give you the depth information. So, I have to say 3D poses definitely better than 2D poses, but that is based on the assumption we got accurate 3D poses. Yeah. And here we use the depth information from the camera.
Yeah.
Yeah, although in my last work, I introduced the method, how do we predict 3D from 2D, but that's based on the assumption we only get RGB information.
Yeah.
But here, if we have the depth information, we can directly use,
Okay.
yeah, as the 3D.
Okay.
Yeah. Mm.
I thought that it was.
Mm-hmm.
I thought that maybe 2D human pose estimation at the moment is better studied and has better performance than 3D.
It is, but I want to give a simple example. For example, if the camera is facing towards me, and if I'm stepping forward, but my 2D poses almost doesn't change. So that's because we lack the depth information. Yeah. Mm.
Any other questions around? Yeah.
I think there's a lot of people have lots of different interesting ideas about different ways we can introduce real world evidence into clinical trials.
Mm-hmm.
You mentioned clinical trial integration
with
this. What do you think are the biggest barriers from your perspective into introducing this kind of evidence?
I think, sorry, are we talking about, it's fine, maybe not here, yeah. I think for the clinical validations in those trials, maybe say from 2 points. One point is how do we really translate, the technical stuffs into the clinical meaning stuffs? Yeah, like definitely we need to collaborate with the clinicians, but we also need to design some metrics that are quite useful. Or sometimes people say it's digital markers, and we need to validate these digital markers really work. But I think there is underlying problem is that sometimes this digital marker work in this set of collected data, but in the real world, like when clinicians do assessment, the environment changes, some setting changes that may affect to this digital biomarker. So it's quite hard to find common and can generalize well to different settings. And even if we have this, we still need to conduct quite large-scale experiments to validate this. So from the algorithm side and the experiment side, it is quite challenging. Yeah, but can be solved step by step, like start from one key point of the symptom and try to propose something to tackle this. I mean, even that also helps a lot. Yeah.
You might have already covered this, but on a high level, how does getting 3D poses from 2D work? Like, do you need to have 3D labels as well, or is there a way to get in 2D to 3D without the depth information?
You mean the depth information?
I'm saying without using depth information. Is there a way to get 2D into 3D pose estimation?
Yeah, sure. That's what my first works are talking about. Yeah. So if without the depth information, people developed quite a few, this deep learning based methods, because like given the data and the human skeleton is a topology structure, and if people are also using one camera to capture this, so the camera's parameters and the human skeleton topology can be inferred through the machine learning of the models. So that's the way of how people do this, that just train the model, input it with, already known 3D pose pairs, and let the model learn this.
Following up on that, so that's mostly in a context of this, like walking around the house or something like that. How would it work in a situation for like someone doing sport, like climbing, for example? Would it still work there, or do you need a lot of training data, of the pose of someone like climbing? Let's say in 3D pose of that person.
I think if we don't train the model, one way is to use the multi-view setting. Yeah, because multi-view, they can give you a triangular setting that can use to solve the geometry inside this 3D information. Yeah. Let me see. Maybe another way sorry, just to say if we don't know, but if we know the camera's intrinsic parameters, we can also use some geometry-based equations to calculate, but this is like a rough estimation. Yeah.
Yeah, following that point, given that in a specific house, you set the camera in a specific position, and then from the 2D image, you actually know, well, you can do some tricks in order to estimate what is the distance to different objects around the house. And if you have a person that you know their size and they walk around, then you may be able to see the layout of the house and estimate also the depth only from the 2D images.
Yeah, I think that can also be categorized into the geometry-based method. Like if we have some reference object, and then we get some, maybe something inferred from the known previous. But I think we can get some estimation, but I'm afraid it's not that precise. And you need to be careful about the settings of the camera. Yeah. And by the way, there are some methods which can predict the depth information just given the RGB images as input. Yeah, there are also such kind of methods that can, I think, help for this question. Yeah.
About the edge computing you show, at which stage is at the moment? How much you can do on the edge? Can you do skeleton? Can you do RAID? Which parts can you manage at the moment from the edge?
Yeah, so for this edge device, because currently we are using this Nano, like different series have different capacities.
Yeah.
This series we have enabled from the 2D to processing RAID here, and now we can achieve about 15 FPS. Yeah.
Okay. Good. Yeah. Any other questions?
No, I think 4 minutes left, and so I think it's a good time to close it.
Yeah.
Thank you for a great
Thank
talk.
you for.
Thank you.